Dr. Bella, thank you very much for the nice introduction. I would like to thank Dr. Fadi for the invitation. So this is an honor for me to take part in your meeting. I've been many times to your beautiful country, and I always enjoy myself coming back here. So Dr. Fadi asked me to talk about malformations, 45 minutes and another 45 minutes. So I have almost an hour and a half. So what I will do is I will show you many images, operations. It will be like a course. I don't know, are we going to stop in the middle or we will make it continuous?
In the middle.
In the middle we stop after 45 minutes. Okay. So I come from Ankara, which is the capital of Turkey. We have a population a little above 5 million. And this is where my university is. It was set up in 1960 by a professor who brought all the Turkish doctors at that time who were studying in the United States. They came to Turkey and set up individual departments. So our ENT department was set up by Professor Hoşal, who saw the importance of audiology in the United States, and our audiology was set up in 1967, more than 55 years ago. And I also, when I was the head of the department, I set up the 4-year audiology school, which I think is very important. That's the reason why we do a lot of ABI cases with good audiology and rehabilitation. So this is our implant team. I would like to acknowledge them. Audiology, rehabilitative audiology. We do the brain stem implants together with my neurosurgical colleague. So all the information that you will see, particularly the audiological results, they come from the work of these people. So I will talk about classification, radiologic characteristics of individual anomalies, surgery, and finally audiological outcome. So when we look at congenital sensorineural hearing loss, 80% are membranous malformations, meaning that the pathology is at the cellular level. And if we do tomography or MRI, we see normal findings. But the remaining 20%, we have the pathology involved in labyrinth, and therefore, when we use imaging, we can demonstrate the pathology. So this is our topic today, this 20% of the cases. In 2002, we published the first classification series. Actually, we modified the existing classification because we were seeing some differences, and everybody was calling everything Mongini. So this is our first paper. At that time, we had 23 patients, and this is our final patients, where we think the classification is come to almost to the end. At that time, we had evaluated almost 700 patients and operated 362 patients. You can find this paper free on the internet, but at the end I will show my email address. If you want any of the papers, I will be very happy to share them with you. So many things comes from this paper. I also had the chance to go to Harvard and work in the histopathology laboratory, which was a very interesting time, because when you see the actual specimens, you learn a lot from them as well, particularly about pathophysiology. And finally, a few months ago, we published a book on malformations, and it has many cases, many images, many videos, so you can find also very much information in this book as well. So we started implantation in '97, and until now we have done over 3,000 cases, and 548 are with malformations. So 384 received cochlear implantation and 164 received ABI. So this is the breakdown of these patients. And if you look, IP2 constitutes the most important indication for cochlear implantation. The second most frequent is cochlear hypoplasia, but interestingly, they are also the most frequent indication for ABI. These IP2, IP3, and enlarged vestibular aqueduct, they always have very well developed cochlear nerve, so they are never indication for ABI, always cochlear implantation. But Michel deformity, rudimentary orthosis, cochlear aplasia, and aperture aplasia are definite indications for ABI. But the problem here is in these three categories, cochlear hypoplasia, common cavity, and IP1. If they have a nerve, we do cochlear implantation. If they don't, we do ABI. So this is the problem that we are still faced today. And if we look at our classification, we have eight main categories, and these first three are definite ABI indications. These are definite cochlear implant indications, but here the problem still continues. We can do cochlear implantation or we can do ABI. So decision in common cavity, cochlear hypoplasia, and IP1 is not only done by imaging. We made the decision by audiology and imaging together. I think this is very important. Even if the nerve is not visible on MRI, it doesn't mean that there is no connection. And if there is a response during audiological evaluation, we prefer to do cochlear implantation. So this is very important at the start. So I would like to start and show the images one by one and what we do in these cases. So the first one is labyrinthine aplasia, described by Michel. So the definition of this is the absence of the cochlea and labyrinth. They are a little less than 4% of the malformations. Of course, cochlear implantation is contraindicated because there is no place to put the cochlear implant, and ABI is the only option. We have performed 22 cases until now in our series. I want to show you some examples. Can you clearly see the images, or is it possible to decrease the lights a little bit? What do you think? Maybe we can decrease the front light a little bit. So this is one example of Michel deformity. Interestingly, you will see that ossicles are always present. Ossicles. So this is otic capsule. This is labyrinthine segment of the facial nerve, and this is a bilateral case. The ossicles are always there. This is a more advanced case. You see part of the temporal bone is absent. Again, we see the ossicles. This is the facial canal here, labyrinthine segment of the facial nerve. So this is another Michel deformity. Look at this. The temporal bone is almost absent. We only have the ossicles here. This is another one. And this is also another labyrinthine aplasia. We have the ossicles here, but you see the brain is very close to the middle ear. So these are all examples of the complete labyrinthine aplasia described by Michel. This is another example. This is actually the first case that I have seen. Very well aerated mastoid, but we don't see the otic capsule here. Again, the ossicles are present, the otic capsule is absent, and inner ear is completely absent. So this is the facial canal, and I noticed that it may be sometimes very difficult to follow the facial canal in Michel deformity, but if we have development of the otic capsule, we can follow the facial canal. So this is one of those cases. We have the otic capsule and we can follow the facial canal, but in patients like this, sometimes we cannot follow the facial nerve through the temporal bone. In the past, this was being confused with the complete labyrinthine aplasia and cochlear ossification, and many times they were reported as Michel deformity. but I think we have to be distinctive between them. So this is the promontory. So if we have the promontory and the round window niche, we have to talk about the cochlear ossification. So this is not Michel deformity, but I remember many cases that they were reported as Michel deformity. So take a look at the promontory and the round window. If they are there, so we are talking about cochlear ossification, so not Michel deformity. Okay, the second group is rudimentary otocysts. At the beginning, I was seeing some remnants of the otic capsule. We were calling them Michel deformity, but I think we have to be specific. So we started to include these under the name rudimentary otocysts into the classification. So the definition is incomplete millimetric representation of the otic capsule. And they are a little less than 1% of the malformations. They do not have internal auditory canal. And the pathology is somewhere between Michel deformity and common cavity. And we operated 5 cases so far with the ABI. So they are less common than other malformations, but we see some millimetric representation developments of the otic capsule. They don't have an internal auditory canal, so we like to term these rudimentary otocysts. This is one example. This is another example. They have the otic capsule development and inner ear structures, but it is not wise to place a cochlear implant in these cases. The third group is cochlear aplasia, meaning the absence of the cochlea. There are 3% of the malformations. Again, the cochlear implantation is contraindicated, and ABI is the only option here. We have performed 17 ABI in this situation, but here there are 2 different forms. So this is cochlear aplasia with normal vestibule, and this is dilated vestibule. So when we look at the tomography, this is a normal internal auditory canal. As Dr. Fari pointed out nicely, the vestibular system is on the posterolateral part of the IAC, and cochlea is on the anterolateral part of the IAC. Here, the cochlea is absent, and this is the labyrinthine segment, dislocated to the usual location of the cochlea. So this is normal, this is cochlear aplasia with normal vestibule. This is exactly the same thing, but with dilated vestibule. So it is very important to know these and differentiate these from common cavity. Okay, so this is cochlear aplasia with normal vestibule. We have a completely normal internal auditory canal, normal vestibule, and this is the labyrinthine segment in the usual location of the cochlea. This is cochlear aplasia with dilated vestibule. Exactly the same image. The only difference is dilated vestibule. So the cochlea is normally here, and the labyrinthine segment passes around the basal turn. But as the cochlea is absent, it is anteriorly dislocated to the usual location of the cochlea. And in contrast, this is common cavity. I will talk a little bit more about this. Here, the picture is completely different. So you see, this is the IAC. It comes and opens directly to the center, and this is much different than from this picture. So this is cochlear aplasia with dilated vestibule, and this is common cavity. The treatment is different, actually. The cochlear aplasia with normal vestibule usually is bilateral, very symmetric, and we can see one example here, and it repeats in the same way in different individuals. It gives me the impression that it is most probably genetic in origin. In these patients, what we do, together with our neurosurgical colleagues, we perform ABI. So this is a retrosigmoid approach. These are 9, 10, and 11, 9, 10, and 11, 11. So this is the foramen of Luschka, where we see the egress of the CSF, and we develop the facial, lateral opening of the lateral recess, and we insert our electrode gently and fully into the lateral recess. Of course, the operation does not stop here, because this is not like cochlea. We do maybe half an hour or sometimes an hour duration of test to determine the exact location. So this is not like cochlear implant that we place the implant into the cochlea. We do tests to determine the exact location of the place for the implant. So we come now to the fourth group of anomaly, which is the common cavity. Common cavity is round or ovoid structure representing cochlear and vestibule. I have seen in many meetings that when there is a wide communication with the cochlea and vestibule, they also call them common cavity. But I think if we can identify cochlea separately from vestibule, we should not use the term common cavity. So these are round or ovoid structures where we cannot differentiate cochlea and vestibule, and this round structure acts as cochlea and vestibule together. There are 6.7% of the malformation. Gushing is present, but it is rare. It is not as common as the other incomplete partition cases. Here, the cochlear-vestibular nerve may be absent. You remember we were doing ABI in some of these cases as well, and we had to differentiate this from cochlear aplasia with vestibular dilatation. So these are all common cavities. If we look carefully, we have a round or ovoid structure like this, and the IEC comes and opens directly to the center. Comes and opens to the center. So this is the differentiation between the two identities. These are all common cavities. You see ovoid structure, IEC comes and opens to the center. This is another common cavity. This is another common cavity. The IEC comes and opens to the center. So when we talk about common cavity, we have an internal auditory canal, comes and opens to the center. But here we have a normal position IAC, normal location for the vestibule, except it is dilated. But why is it so important to make this differentiation between them? So in a patient like this, the nerve entering here most probably is vestibular nerve. So if you place a cochlear implant here, we will try to stimulate the vestibular nerve, which is logically not giving us very good outcome. But here, the nerve entering here carries cochlear and vestibular fibers, and we may produce good outcome with cochlear implantation. How are we going to decide between cochlear implantation and ABI? Look at this case. So on the left side, we have a common cavity, very nice developed internal auditory canal. So if we have a nerve, I think it's a good thing to do cochlear implantation on this side. But look at this other side. We have a very tiny common cavity, and the internal auditory canal is extremely narrow and long. So I think imaging is very important. If we look at this, we can think that the size, if present, the size of the cochlear nerve is not very good, and also there is no place, sufficient place to place the cochlear implant in these small cavities. So in patients like this, choosing ABI from the right from the start may be a better option. So I think it is very important. Each patient is different, so look at the scans carefully. So the nerve entering the common cavity is proper term is cochleovestibular nerve. So this is not a cochlear nerve, this is not a vestibular nerve. The correct terminology is cochleovestibular nerve. And it is usually 1.5 times larger than the ipsilateral facial nerve. So let's see some examples. So this is a common cavity, this is a common cavity, and the nerve entering the common cavity is cochleovestibular nerve. This is the facial nerve. So I suggest when you have the tomography and MRI, you look at the facial canal on tomography, and then you can have better estimation which nerve is common cochleovestibular nerve and facial nerve. You can have better estimation of the nerves. So this is the facial nerve, and the size of the CVM on both sides is okay. So I prefer to do bilateral cochlear implantation in this particular case. But if you look at this particular patient, again we have bilateral common cavity. We have a good size CVM here, but look at this side. So this CVM on this side is hypoplastic. So if you make a cochlear implantation, you know, already we are not sure about how much there are cochlear fibers in CVM, and if there is, in addition, hypoplastic CVM, it is very difficult to expect a good outcome. So in patients like this, it may be better to choose AVI on this side and cochlear implantation on this side right from the start. We operated 26 cases, common cavity, 4 of them revisions. We used transmuscular labyrinthectomy and also double labyrinthectomy. I will show you some examples. We had 4 gusher. So gusher is possible, but not as frequent as the other anomalies. We prefer to use electrodes with full contacts or full rings or contacts on all surfaces. Why? When we look at the common cavity, we're not sure about the location of the neural tissue, so we want to stimulate as much as possible. So if we use electrodes which is curled in the middle, modellar hugging electrodes, we may not stimulate sufficiently. So we prefer to choose electrodes with full rings or contacts on all surfaces. We should not use modellar hugging electrodes, and we should take the X-ray in the surgery. How are we going to decide the length of the electrode to be used? You remember in the primary school, we learned this formula, 2PR, to measure the perimeter of a circle. And I think we can use this here. I suggest there is a program called Radian. I learned a lot from the Radian program. You can do every measurement by yourself. So I think this is very easy. You just measure this dimension, and if you use this formula, it gives you roughly the length of the electrode, which will make one full turn around the common cavity. So then we can choose the electrode according to this. There are 2 methods described by the first one, transmuscular labyrinthectomy, described by John McElveen in 1997, and Beltrame, double labyrinthectomy technique, later in 2000. So McElveen pointed out that we can make opening labyrinthectomy and enter the common cavity, and I think this is a very useful technique. And in the first common cavity patient that I operated, I opened the facial recess and I was looking for the cochlea, but in these patients there is no cochlea, so there is no reason to open the facial recess and go to the front. But the common cavity is a posterior structure which you can easily reach after mastoidectomy. So the common cavity is here. If you remove these cells, you will identify the lining of the common cavity, and this is incus here, incus is here. So this whole thing is common cavity, and anywhere along the common cavity by making a opening. So this is labyrinthotomy. This is not cochleostomy, labyrinthotomy. This is the original prototype of the form electrode. You just insert the electrode into the common cavity. It is easier than the normal standard operation. So the electrode is nicely inserted into the common cavity, and at the end of the surgery, we see the electrode making a loop in the common cavity. So this is the insertion, and it makes a loop. This is very good. But you know, in operations, we can have some problems as well, and we need to identify these and correct them. So this is another 2-year-old female patient, common cavity. You see the internal auditory canal, very good nerve, and you know, the operation was very straightforward. We didn't even record the operation, but if you look at the post-operative X-ray, which I suggest you always make this X-ray after surgery, and we see that the electrode makes a curl and then goes into the internal auditory canal. So during the operation, if there is gusher, you have to take the X-ray intraoperative. But in this particular patient, there was no gusher at all. So we take the X-ray afterwards, and when we see this, we made CT. Normally we don't make CT to avoid radiation, but it was very different, and I have seen this, so we have to correct this patient. How are we going to do it? We can do it with double labyrinthotomy. So we make 2 openings and insert the electrode through one of them and get the tip from the other one. So in this way, we avoid the tip going into the internal auditory canal. So this is what I have done. And this is the operation. After the operation, I take out the electrode. You see it is curled, and there is no CSF leak. And it is very interesting how it went into the internal auditory canal with a curve like this, but we have to prevent this. I don't want that to happen once again. So the only thing I can do is double labyrinthotomy. So in this particular patient, I make another opening here, So we will insert the electrode from here and get the tip from the other side. This is our aim. In this way, we will prevent the tip of the electrode going into the internal auditory canal. So I suggest you to make the 2 openings close to each other, and it is also very, very important. So now the 2 holes are connected. Another important thing is to make a groove here. Why? If you don't make this, it is more difficult to insert the electrode and get the tip from the other side. But if you make this groove, then the electrode tip, it is easier to get it from the other side. So the 2 holes should be close together, and if you make the groove, it is much easier. Then what I have done is I inserted the electrode. The posterior part of the electrode is inserted gently into the common cavity, like this. Now we are sure that the tip is not in the internal auditory canal anymore. So the posterior part is gently inserted into the cavity. As you see, there is no CSF leak, and the tip is pushed a little bit into the common cavity. Now we are sure that the electrode is not in the internal auditory canal. Then I place soft tissues around the electrode because we don't want a middle ear infection should pass through here. And this is the postoperative view of the electrode. Nice curl in the common cavity. And this also happened in this particular patient. You see, in this particular patient, there was CSF leak. So I take the X-ray in the operation. It was like this, and after double labyrinthectomy, I changed it into this position. So while I tell you this, we're doing these surgeries, we must be ready for problems, but we have to solve the problems as soon as possible, reposition the electrode to provide as maximum benefit as possible to the patient. So we have finished the common cavity as well. And the fourth group is cochlear hypoplasia, which is an interesting category. And from now on, you remember in common cavity, we have a common structure, ovoid structure, representing cochlea and vestibule. But now, we can identify the cochlea separate from the vestibule. So if the dimensions of the cochlea, if the external dimensions of the cochlea are less than normal, we talk about hypoplasia. If external dimensions are similar to normal cochlea, we talk about incomplete partition. So this is the definition between them. Common cavity, cochlear hypoplasia, and incomplete partitions. So let's look at the cochlear hypoplasia. Here the external dimensions are less than normal cochlea. They are 25% of the inner ear malformations. You remember, they are the largest indications for ABI and second largest indication for cochlear implantation. Interestingly, hearing is variable. We can have patients with sensorineural hearing loss. We can have mixed. We can have also pure conductive. And there are a number of patients whom I perform staples surgery. I will show one example. In some patients, hearing aid is sufficient, so not all of them need cochlear implantation. And in these particular patients, cochlear aperture may be hypoplastic or aplastic, meaning that cochlear nerve is absent. And you remember, we have done ABI in 51 cases. And these patients have one other interesting feature where the facial nerve is anomalous due to the associated semicircular canal abnormalities. And facial nerve abnormalities is most frequently seen in this group. There are 4 different forms. So this is a normal cochlea. We have a basal turn, middle, and apical turn. This is cochlear hypoplasia type 1, where we have a tiny bud-type cochlea. This is cystic type of cochlea. Again, the cochlea is small, but there is a risk of CSF leak. Here, the outcome of cochlear implantation is not very good. There is a risk of gushing. This is cochlear hypoplasia type 3. We have a modulus, but we only have 1.5 turns of the cochlea. In the literature, you can see that they use the term 1.5 turns of the cochlea for Mondini cases, which is wrong. 1.5 turns should be used here. And we also describe the fourth group, where we have a basal turn, normal basal turn, and tiny apical turn. So these are all hypoplasia. This is bud-type cochlea. The outcome is not very good. This is cystic hypoplasia, where there is a risk of gusher. This is cochlear hypoplasia type 3. You see modulus, but small basal turn and tiny middle and apical turn. And this is type 4, where we have a normal basal turn, but very tiny middle and apical turn. So these are the 4 groups. And this is bud-type cochlea. This is cystic type cochlea. There is a risk of CSF leak. This is, we have to separate these from IP1, don't forget. We have to separate these from normal cochlea This is cochlear hypoplasia type 3, and this is type 4, where we have basal turn and middle and apical turns are very small. But how are we going to decide if the cochlea is normal or hypoplastic? Many people were asking me this question. I think it is very important, and we need a study. And after all the measurements, this is very, very simple. And we come to the conclusion that if you measure this distance from the round window to the anterior part of the basal turn, and if this is less than 7.5 millimeters, we can use the term hypoplasia, just as this case, 5.5 millimeter. Then we choose smaller electrodes, thinner electrodes for these cases. So, I told you not all cases need cochlear implantation. For example, a case like this, we can use hearing aids for rehabilitation, and he or she doesn't need any implantation. But we also have patients with air bone gap. So this is very frequent to have air bone gap in these patients. At first, I was thinking that this is due to otitis media with effusion. But then I realized that if the cochlea is smaller, most probably the stapes is not fully developed. We can have stapes fixation in these patients. And we have done a number of stapedotomy in these cases and published in this paper. You can find more information here. I want to show you one patient. So this, you know, we have a very good audiology clinic, and they always bring me these cases, children, no effusion but conducting hearing loss. So this was a 3-year-old male patient with huge air bone gaps like this. And when we look at the tomography, you see the facial nerve is only promontory and inferior to the oval window. So the facial nerve should always be here. But if you see here, usually the stapes is missing. And you see, this is the operation of this particular patient, cochlear hypoplasia. This is the facial nerve here. This is the facial nerve. And this is incus and stapes. The system looks mobile, but there is no stapes. The stapes is not touching the oval window. So in this particular patient, I drew the presumed location of the oval window. It was very difficult, and because there is no landmarks here, and you will see what happens now once we open. There is a CSF leak. You see the CSF leak. In this particular patient, we have to close the opening very well, and we have to vaccinate the patients properly before doing the surgery. But you know, we are used to these CSF leaks. I pass the Teflon piston through a tiny fascia, just like we do in cochlear implantation, and I insert them into the opening. It is important to choose a thin piston for this purpose, because if we use a thick piston, it is very difficult to put the fascia around the electrode, around the piston into the vestibule. So this is what I have done. You will see that we have the reflex. You see, this is the round window reflex. This is the facial nerve in an abnormal location. And so I operated the first ear at the age of 4, the other ear 5, and this is bilateral, very good thresholds in this particular patient. And this is another patient, cochlear hypoplasia type 3. We see that there is basal turn, but almost very tiny middle and apical turn, but the nerve is there. The nerve is there. So this is the hearing. When we do stapedotomy in this patient, many of us will not. But I have done bilateral stapedotomy, and at first there was no thresholds here, and of course the gap is not fully closed, but the patient made much better benefit from hearing aids, and the language was much better after the stapes surgery. So in these patients, stapedotomy works well, and we have to think about staple surgery in these patients, but not in IP2 and IP3. This is contraindicated to do staple surgery in these particular abnormalities if we see enlarged vestibular aqueduct and modular defects. Just as Fatih pointed out, this is due to the third window phenomenon, and if we do staple surgery here, there's a huge gusher and we can lose the remaining hearing, so it is contraindicated to do staple surgery in these cases. But normally, cochlear hypoplasia patients, we have thresholds like this, and this is more common. We look at the scans. So this is cochlear hypoplasia. We can see the cochlear nerve here and hypoplastic nerve here. If we see the nerve like this, we always go for cochlear implantation. But if we see a cochlear hypoplasia and there is no cochlear nerve here, then we have to think about ABI. Of course, together with audiological decision. So this is very important. We operated 104 patients, and 11 of these had gusher. So true gusher is possible in hypoplasia, and we have to be ready to manage these cases. Measuring the dimensions of the cochlea is very important because we have to choose thin and short electrode. So it is very important. Otherwise, if we use a long electrode, we may not be able to insert the electrode fully into the cochlea. And we have to take the X-ray in the operation, particularly if there is gushing. So determining the length is very important. We have to use short and thin electrodes. In incomplete partitions, we have to use electrodes with normal length. So if you look at this patient, you think that there is IP1 on both sides. But if you measure them carefully, this is IP1 and this is cochlear hypoplasia. And it is very frequent to see both of them at the same patient. And therefore, I noticed this and I choose form 24 on the IP1 and form 19 on the cochlear hypoplasia. But let's look at them more carefully. If I had chosen form 19, it would stop the leak, but it would make a turn like this. But if we choose form 24 here, most probably the electrode stopper will be out of the cochlea and not efficient. So this is what I'm trying to say. We have to make these measurements very simple. From the round window to the anterior part of the basal term, and if it is above 7.5 millimeter, we use longer electrodes, and if not, we use shorter electrodes. There is some surgical problems. Electrode may not be inserted fully into the hypoplastic cochlea, and migration is possible. So be careful with this. So this is a patient who was sent to us for ABI, and I also saw that there is a nerve and also response on one side. So we decided to make a cochlear implantation here, but if you look at the tomography, we have a tiny, tiny basal turn and nothing else. So we won't be able to insert the electrode fully. So let's see what happens. This is a electrode with cochlear 42, but as soon as we reach the end of the basal turn, the electrode does not go in. So we stop here, but we have to secure the electrode lead properly. So I'll insert this into the attic and put a lot of fascia around here so that stabilizing the electrode here at the cochleostomy and also here in the attic, I think is very important because if we cannot insert fully, the electrode may come out of the cochlea easily. Partial insertion is something we have to think about, And if there is a gusher, particularly in cochlear hypoplasia type 2, we have to use form electrodes. The stopper should be at the cochleostomy, and so this is hypoplasia type 2. But if we use a longer version, form 24, we won't be able to insert maybe until the stopper. So we developed a shorter version, form 19, with the stopper, particularly for these cases, so that the stopper will be at the cochleostomy. As I said, the facial nerve abnormalities is most frequently seen in cochlear hypoplasias. Roughly 1/3 of the cochlear hypoplasias have abnormal root. You can find much more information in this paper. If we look at the IP1, 2, and 3, external dimensions of the cochlea and vestibule are near normal, and we do not see facial nerve abnormalities except in IP3, where we have labyrinthine segment superiorly placed. But this does not create any problem during the surgery. I'm just about to finish. But in cochlear hypoplasia, the facial nerve is abnormal because the cochlea and semicircular canals are hypoplastic, and it puts the tympanic segment in a different location. For example, this is the normal location of the facial nerve. We can have superior displacement at the oval window or inferior to the oval window. So these are possible. And if the facial nerve is abnormal there, we can have problems in the facial recess. So when we do cochlear implantation, we look through here. So this is the facial nerve, this is the ear canal, to be able to reach the round window. This is very important. But this is the cochlear hypoplasia. Look, we have a very, very narrow facial recess. So it is very important that our radiologists inform these abnormalities to us to see that the facial recess is narrow. Then we have some problem. For example, this is normal. Look, the facial nerve is here. On coronal sections, it's inferior to the oval window. I want to show you one example where the facial nerve is on the promontory. So if the facial nerve is on the promontory, it is not here. So this was the case, and this is the stapes. The facial nerve is inferiorly located, blocking our view to the round window. And in this particular case, I make a groove here so that I will stabilize the burr while I make the opening into the cochlea. So this is a 1 millimeter burr stabilized here because, you know, the facial nerve doesn't have the bony coverage here, and we can easily damage. I managed to open it, and the electrode was fully inserted into the hypoplastic cochlea without any problem. But this is evident on preoperative tomography, and this is what I wanted to show you. I think it is very important to notice this. And in this particular patient, we had an AVI at the same time. This is the CI and AVI. I will stop here. We will make the company presentation and then continue later on. Thank you very much.
Question?
We'll make the questions at the end of the second session. Now, can I introduce to you Cochlear Company and engineer Nina Alfi will give us a brief introduction to what Cochlear